rehabilitation session hosted by Health Professions Strategy and Practice. The purpose of these sessions is to share clinically relevant information and experiences, followed by an opportunity for a question and answer session. The information provided is intended for an AHS audience. Other staff groups may find the material applicable, but are responsible for aligning it with their own clinical policies and procedures. Please note that this session, along with the question and answer period, is being recorded. The recording, slides, and links will be posted on the COVID-19 Rehabilitation and Recovery page on ahs.ca, as well as the PracticeWise page on Insight. Please note that this session, the recording, and the materials presented as part of the session are the copyrighted materials of Alberta Health Services, with the exception of any video material you'll see today. We will remove the video clips from the recording, but provide you with links to the videos for your review at a later time. We actually will not have a Q&A session today in this session since it is being pre-recorded, but we do invite you to contact the speakers directly if you have any questions about the content. We want to acknowledge and celebrate National Indigenous Peoples Month throughout the month of June. It's a time to recognize the cultures and stories of First Nations, Inuit, and Métis people across this land. We acknowledge that we are gathered virtually today on the territories of Treaty 6, Treaty 7, and Treaty 8, and Métis Regions 1 through 6. These territories are home to many Indigenous peoples, including the Blackfoot, Cree, Dene, Saulteaux, Ojibwe, Stoney Nakoda, Sioux, and Tsuut'ina peoples, the Métis Nations of Alberta, and the 8 Métis settlements. We respect the treaties that were made on these territories, we acknowledge the harms and mistakes of the past, and we dedicate ourselves to moving forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. And now I'd like to introduce our speakers for today. Laura Bernard is a provincial rehabilitation senior practice consultant with Allied Health Professional Practice and Education and is also a physical therapist. Damien Sarnecki is an Edmonton-based registered psychologist and the provincial professional practice lead in psychology with AHS's Allied Health Professional Practice and Education team. While working in primary healthcare, he helped to develop the youth mental health hubs in Alberta and has background in school counseling, child and teen residential treatment intake and assessment, and pediatric obesity treatment provider support. Dr. Alison Byrne is a registered psychologist and the discipline lead for psychology at Alberta Children's Hospital, Calgary. Alison's primary clinical interests include pediatric medical psychology, child and adolescent mental health, and child development. Alison received her doctorate in clinical psychology in 2006 from University College Dublin and worked in pediatric and mental health services in Ireland before moving to Calgary in 2014. Our hope today is that we offer you some valuable information to support you as you strive to best meet the needs of your patients and families in your professional practice. In our session today, we plan to highlight why it's important to take a whole person perspective when working with post-COVID pediatric patients and families, key psychosocial considerations, tips to help inform your practice, and using a case example, illustrate how a holistic approach that weaves attention to the psychosocial considerations can occur. It is important to note that this presentation will not be an exhaustive review of all psychosocial issues related to post-COVID-19 in the pediatric population. For a more exhaustive review, we'd like to refer people to May 25th, 2022 University of Alberta PGR, Coping with COVID, Psychosocial Impacts of the Pandemic on Children and Families by Dr. Catherine Jensen and Dr. Courtney Larson. This offered a comprehensive review of COVID-19 on children, teens, and families. Our presentation today will mainly cover the changes that were made to adapt the adult rehabilitation and allied health practice considerations for post-COVID-19 in pediatrics. There will be some information on long COVID related to pediatrics, but given the current knowledge base, we decided to include mainly general communication and interaction considerations and tips about working with families in a healthcare environment. Now, I'd like to turn it over to Laura Bernard.
Thanks, Allison. So before we start the survey or the formal presentation, just want to take a second and have everyone think about how confident you are right now in your knowledge on how to manage the psychosocial aspects of post COVID conditions in children and youth? Just take a moment to ponder that. So, with that in mind, I'll talk briefly about what we currently understand about post COVID and its impacts. Most people who become infected with COVID-19 recover within a few weeks, but some people, even those who had a mild infection, continue to experience symptoms beyond the acute phase. This has been referred to as post COVID syndrome, long COVID, persistent post COVID, and more. The World Health Organization has defined these long term symptoms as post COVID 19 condition, which occurs in individuals with a history of probable or confirmed infection, usually 3 months from the onset of COVID 19, with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. Some of the common signs and symptoms that linger over time include fatigue, weakness, activity intolerance, sleep difficulty or insomnia, muscle and or joint pain, headache, concentration or memory difficulties, and sensory problems. But the question that we've been grappling with is this. We've known about long COVID in adults for a while, but what about in children and youth? I'll take a couple minutes to talk a little bit about how we've come to understand long COVID in children and youth here in Alberta. Back in the summer of 2021, we began to receive questions from clinicians about children that have been referred to their services having concerns with functional limitations after a COVID infection. Following discussion with the Provincial Post-COVID Task Force and the Maternal, Newborn, Child and Youth SCN, a Pediatric Post-COVID Resource Working Group was established. This working group included allied health clinicians and physicians from across the province. They had three key objectives. First, to incorporate pediatric content into the Rehab and Allied Health Practice Considerations document, which was just posted. Second was to develop primary care guidance for rehabilitation referrals, which is in process. And finally, to identify recommendations for next steps in our province, such as universal and targeted resources and referral pathways for specialty services. To do this work, they completed both a literature scan and an environmental scan. So I'll give you the Coles notes of the literature scan. Since this is a new presentation and we're learning more about it every day, there were overall study limitations. Poor quality, lack of controls, low numbers of participants, selection bias, which combined with varying definitions of post-COVID limited our ability to draw any firm conclusions. So please take everything with a grain of salt. The incidence of long COVID presentations ranged from 0% in a hospitalized cohort to up to 66% in children reporting at least one persistent symptom in a small cross-sectional study. However, some clinicians have proposed that a more reasonable number is likely between 5 to 10%. Another finding was some overlap in several studies with prolonged symptoms present in children and youth without a confirmed or suspected COVID infection, leading some to propose that somatic symptoms may also be present. This graph shows the number of COVID cases per 100,000 in Alberta by age group. Early on in the pandemic, COVID infections were more prevalent in our adult populations, but you may remember that in wave 4, children aged 5 to 11 had the highest 7-day rolling average of new daily COVID-19 cases for several weeks in a row. In Alberta, waves 3, 4, and 5 impacted our children more so than in previous waves. So when earlier in the pandemic, we were hopeful that post-COVID did not impact children, we now know that Alberta children are presenting with post-COVID symptoms and functional limitations. Based on COVID-19 Alberta statistics accessed on June 2nd, Alberta had recorded almost 100,000 children and youth aged 5 to 19 years who'd had a confirmed COVID infection. We know that these numbers likely underestimate the true number of COVID infections in Alberta. But if we take a low estimate of 5% or a moderate estimate of 10% of children and youth, that's between 5 and 10,000 children and youth who may have persistent symptoms after a COVID infection here in Alberta. Now, many of these children will recover on their own or will be able to self-manage using universal or targeted resources. We don't yet know the true number of Alberta children and youth who will benefit from more intensive rehab services, but we can provide you, as clinicians, with some tools to support your practice if or when you receive referrals for children with ongoing symptoms that are impacting their function. From a treatment perspective, the key themes in the literature included the importance of self-management and rehabilitation from a biopsychosocial lens, with a focus on child's goals, not the diagnosis or investigations. Rehab should focus on relieving symptoms and preventing complications, with considerations to the impact on daily functioning and participation in meaningful activities for the child, youth, and family, including sports, school, hobbies, and social activities. So the answer to the question, do children experience persistent symptoms following COVID-19 infection, is yes. And I'd like to encourage you to take a look at this short video from Long COVID Kids. It touches on how kids are experiencing long COVID. As I said earlier, a strong biopsychosocial approach is key to helping children, youth, and their families address the impacts of post-COVID. So I'd like to pass it on to Damien to speak about some key psychosocial treatment considerations.
Thanks for that review, Laura. So before we proceed to discuss the psychological considerations of long COVID on the pediatric population, I'd like you all to consider the girl in the video we're posted here, Liliana, and the symptoms she describes. As you watch the video, take a moment to think about how these symptoms might affect her psychologically. And as we talk about post-COVID and children and teens, consider how you might apply some of the things we reviewed today if she was your patient. So the amount of specific research on the psychosocial effects of post-COVID conditions on the pediatric patients and families is limited but diverse. But the amount of literature, as Laura had mentioned, on the effects of COVID pandemic on children and teens generally is starting to be quite substantial. And as noted, the psychosocial effects on children and teens have been documented worldwide. For example, even in Turkey, in studies in Turkey, recent results showed that up to 49% of participants had anxiety symptoms, 30% had depressive symptoms, and 50% had irritability symptoms. In terms of risk, younger age was determined to be a potential risk factor for anxiety, and female gender was potential risk for anxiety and depressive symptoms. Having a COVID death in the family or home environment was also just suggested to be a potential risk factor for depression and irritability, while television and internet exposure to COVID-19 information was found to be a potential risk factor for anxiety, depression, and irritability. Similar results were reported in these negative effects on children and mental health in other countries, such as Italy. And recent studies in Italy added that other potential risk factors included social isolation, higher levels of parental stress and poor parent-child relationships, low socioeconomic status, and the presence of pre-existing mental health conditions. Next slide, please. Now, in North America, the United States Department of Health and Human Services did a big study in 2021, and it suggested that following a COVID-19 diagnosis, adolescents were almost 4.5 times more likely to experience depression than younger children aged 6 to 11. The pre-existence of adverse childhood experiences, such as abuse and neglect, death of a family member, addiction in families, and certain psychosocial events like criminality in the family substantially increase the likelihood of young people experiencing a mental health condition post-COVID infection. Parental mental health concerns have also been found to be associated with the children's mental health. Next slide, please. As Laura hinted at, too, one of the biggest review studies done by Zimmerman in 2021 indicated that even though the risk of coronavirus being severe in children was low, the risk of persistent symptoms following infection is uncertain due to various limitations of studies, they concluded that long-term or post-COVID infection-associated symptoms are really difficult to distinguish from pandemic-associated symptoms and difficult to distinguish just from non-pandemic associated symptoms. Next slide, please. So what are we to do? In discussing preparing for this presentation, we brainstormed what topics we should be covered. Given the lack of knowledge on all the psychosocial effects of post-COVID, we decided against going through statistics of every single psychosocial factor and post-COVID, as those statistics aren't really necessarily helpful with practice recommendations for treatment. Instead, we focused on developing a session on supporting clinicians of varying disciplines in their interactions with post-COVID patients and their families and caregivers. A lot of what we review today may already be known by most of the audience, but we encourage you to see this as a timely review of existing knowledge that can be utilized with post-COVID pediatric patients and their families. As mentioned before, we also encourage you to think about how you might apply some of these strategies in your work with post-COVID patients. Next slide, please. We had originally intended to do some knowledge checks, and I encourage you to test your knowledge as even during this recording with these questions. Question is psychological factors and children and teens with long COVID are A, easy to distinguish from non-COVID related issues, B, difficult to distinguish from non-COVID related issues, and C, not sure. I would give time to answer the question, but let you think about that for a few seconds. And of course, the correct answer for this is B, psychological factors with children and teens with long COVID are difficult to distinguish from non-COVID related issues. Now, our patient first strategy at AHS speaks to the importance of addressing what matters to patients, things that matter to them from a psychological perspective. And attending to these needs as part of a holistic approach, we are better able to meet our goal of providing patients and families with the best possible healthcare experiences. Next slide, please. Within AHS, it's important that we recognize the important role of psychological, spiritual, and social considerations in health and patient care, and we see this reflected in many foundational frameworks and strategies. For example, the rehabilitation conceptual framework emphasizes that people are at the center of rehabilitation in AHS. Quality rehabilitation comes from professional practice that is person-centered, holistic, integrated, and guided by evidence. And rehabilitation enables and encourages people to identify, reach, and maintain their cognitive, communicative, emotional, physical, psychological, social, and spiritual health goals. It's also important that we look to research and evidence-based practice guidelines, and it's noteworthy that in this slide, you can see the quote that in the National Institute of Healthcare Excellence's COVID-19 Rapid Guideline on Managing Long-Term Effects of COVID-19, the need to adopt a holistic person-centered approach to clinical assessments is explicitly identified. So what we want to take away from this presentation is note that self-management is essential to optimizing health outcomes for those recovering from symptoms of COVID-19. However, pediatric patients require support from their family and caregivers to improve their confidence, knowledge, and skills to manage the physical and social emotional impacts associated with their illness. Developing support capabilities of caregivers begins with interaction between healthcare staff and patient and family, and effective communication not only ensures a shared understanding of matters at hand, but also serves to build a trusting relationship between patients, families, and healthcare staff. In terms of communication practice tips for working with pediatric patients and families, we really encourage you to use patient-centered communication strategies because communication is such an important tool in any interaction between a healthcare professional and patients and families. And it has also been shown to improve patient satisfaction, patient knowledge, comprehension, treatment adherence, and health outcomes. And managing cases of long COVID is no different in this respect, and thus reviewing patient-centered communication best practice strategies may be helpful in bolstering communication skills and improving your understanding of how communication may serve to help improve outcomes the role communication plays in healthcare interactions, and identify skills which may help you enhance your approach to patient-centered communication. In terms of these practice tips, we're going to be referring to, although they were specifically written about patient-physician communications, the 2013 Best Practice for Patient-Centered Communications Review provides an excellent overview of patient-centered communication, which is applicable across healthcare professions. They provide a 3-task framework to help clinicians navigate acknowledging and communicating uncertainty with patients. Next slide, please. The first task is to normalize the uncertainty in prognosis. It's important to acknowledge that limitations to our medical knowledge and diagnostic investigations. Although we would like to be able to provide more certainty on what may cause a given symptom, in almost all cases, total certainty is not possible. Normalizing that having uncertainty is a normal part of illness, while also acknowledging that there is more uncertainty about long COVID than other conditions, because it is new, it is less researched, and it does not have a diagnostic test to confirm the diagnosis. This may be helpful when paired with the other 2 tasks in the framework. But in doing and normalizing that uncertainty, take care to try not to dismiss the importance and emotional impact of the actual uncertainty with patients. Next slide, please. Task 2 is address the patient's and family's emotions about uncertainty, acknowledging how difficult it may be for them not to know. Some patients and families may become focused on seeking answers to the uncertainty and to necessarily unanswerable questions. To a degree, this knowledge seeking helps definitely alleviate some uncertainty. It's a normal part of helpful behavior, but if the distress or emotional intensity of it or focus on seeking those answers become barriers to actually even engaging in treatment, the patient or family may need to revisit their physician or family doctor to discuss the steps that were taken to arrive at the diagnosis and or to explore their current mental health and coping. Be cautious, though, in the use of statements of reassurance, such as the doctors have ruled out everything bad, because in the face of uncertainties, many such statements may be perceived as dismissive of the patient's or family's experience and the impact long COVID may be having on their lives and their functioning. Instead, try to focus on statements of validation, such as, it makes sense to me how you could be feeling X given Y is happening, and help the patient to identify actions that are within their control. For example, such as actually engaging in treatment, things that may help them achieve what they want in the future. And this is where practices such as SMART goal setting, which some of you may be familiar with, may be helpful. Task 3 is to help patients and families manage the effect of uncertainty on their ability to live in the here and now. Try to focus the patients on focusing on the current moment. It can be a really effective way to help manage uncertainty regarding what is in the future in relation to one's health and one's quality of life. And allied staff have a critical role to play in this, as many of the therapies or symptom treatment options outlined in this document help to address the symptoms which may be causing the greatest disturbance in a patient's usual function. Again, this is where the use of goal setting, basing and encouraging self-management strategies may be helpful. That brings us to another knowledge check. We want you to consider, when working with pediatric patients suspected of having post-COVID related mental health issues, which of the following is true? A, self-management is essential to optimizing health outcomes for those recovering from symptoms of COVID-19. B, children and youth do not require assistance to manage their post-COVID symptoms. C, children and youth require assistance. D, options A and C, or none of the above. So I'd like you to consider those, and the correct answer would be options A and C, which would be D. Next slide, please. Now, some additional practice tips when working with pediatric patients and families that you are all familiar with is definitely approach patients and families in a calm and caring manner, making eye contact and trying to speak at an unhurried pace. However, be cognizant that not all cultural groups interact in this specific manner. For example, some cultures make less eye contact during conversation or while listening, and more eye contact when they want to have than when they have something to say. Try to create a safe place for pediatric patients to share and build trust and rapport. And part of that comes from being curious. Try to ask open-ended questions in a narrative way to find out what matters most to the patient, to the kids we work with and their caregivers. And that means, a lot of questions with what and how, and questions basically cannot be answered with just a simple yes or no. And in asking these questions, it helps build rapport, but try not to do it in an interrogative fashion. Try to use normalizing language that emphasizes that stress impacts people in different ways and that different people cope with it in different ways. Additional practice tips, take time to take care and to confirm and validate the child's or teen's reported troubling symptoms, as mentioned earlier, as well as any related issues that the family or caregivers may mention. This not only helps the patient and family feel heard, but serves to ensure correct understanding between the patient and family and the healthcare provider. Try to also use familiar wording at the developmental level appropriate for the pediatric patients and their caregivers. Some of the more complex medical terminology and diagnoses may require explanation, so try to avoid using too much medical jargon and explain things in a way pediatric patients and their families will understand. Some additional tips, continue to use active listening skills such as summarizing and paraphrasing to ensure your patient or family member and the caregiver and you are understanding each other. Even offering practical suggestions during. So if you notice, a child is anxious and about the whole situation, it doesn't hurt just to ask them to stop, slow down, take a few deep breaths to reduce their anxiety. And continue just being curious and asking questions like how things are going. What would you like to talk about related to what's going on? What have you been finding challenges with how you're thinking or feeling? Questions along those lines. Some additional tips. Recognize that the impacts of the pandemic influence us all in different ways. And next slide, please. So this video we'd like to play is just a video AHS did with Dr. Nick Mitchell that will introduce you to some of the coping mechanisms and how children deal with stress and some general tips. So we want to encourage parents to really monitor their children or teens for signs of distress, which may indicate some mental health issues going on in any child, but particularly post-COVID kids. Signs of stress and mental health challenges aren't the same for every child or teen, but there's some common signs and symptoms associated with these issues that are different for certain age groups of pediatric patients. Infants and younger children may show a decline or a regression in their developmental level, and caregivers need to monitor their child for things like an increase in fussiness or irritability, startling, or crying more easily, or the child is difficult to console when they're upset, trouble falling asleep or waking up more often during the night, feeding issues such as nausea, vomiting, constipation, or loose stools, complaints of stomach pain, an increase in other sleep issues such as trouble falling asleep or waking up more during the night. Next slide, please. Infants or younger children may also, demonstrate an increase in anxiety when they have to be away from their family, some clinginess or not wanting to socialize, or they fear going outside. There could also be an increase in aggressive behaviors such as hitting or biting, or more frequent or intense tantrums. Also, bedwetting after a child has successfully been potty trained would also be another source or sign of distress. In terms of older children and teens, adolescents, they're somewhat different from younger children, but encourage parents to watch for changes in mood in the child that are unusual or uncharacteristic, such as increased irritability, feelings of hopelessness or anger, or more conflicts with friends or family or school staff. Other changes in behavior, such as increased withdrawal from personal relationships, or a usually social, chatty child is turned into a recluse. Um, a loss of interest in previously enjoyed activities or interests, or an increase in sleep issues, such as the time falling asleep or staying asleep, or feeling tired and sleepy all the time. Teens and adolescents should also be monitored for changes in eating patterns and appetite, such as not eating a lot or feeling hungry all the time, and a marked increase in or decrease in weight. Body weight may also be a cause for concern, as well as changes in appearance, such as a decrease in normal personal hygiene activities. Other things to watch out for would be trouble with memory, thinking, or attention and concentration, which may accompany an decreased interest in schoolwork or a drop in academic effort or performance. There also might be an increase in risk-taking behaviors, such as using drugs or alcohol, or even expressed thoughts of comments about death or suicide, or engage in self-harming behaviors or reckless behaviors. And this is part of encouraging parents to regularly check in with their child and ask them how they're doing or feeling, and just reminding them that they're to talk when the child or teen is ready. And reminding parents that some children or adolescents may require more time or space to express themselves. Some might do better with gradual conversations, others might do better with more direct conversations. But if they can't talk to the parents, encourage the parents to try to encourage the teen to talk to a trusted friend or another family member if they don't want to talk about necessarily things with their parents or their primary caregivers about all their problems. Now, during the pandemic, due to the contact restrictions or due to the post-COVID conditions, in addition, children or teens may not be able to physically interact or talk in person with their peers or trusted adults. In such cases, all attempts should be made to try to ensure that the child has access to other forms of interpersonal action, such as online playdates for younger children or online chats and text messaging for teens. And parents may need to also play an active role with their child's friends, caregivers, and their child friends to arrange such opportunities to ensure the child feels connected to a support network. They feel supported by their peers, friends, and their family, and has some time to do some socialization if they can't do it in person. For older adolescents and teens, that support should include some form of private communication to give their child some feelings of independence and be able to interact freely with their peers, but within reasonable time limits, of like a certain amount of screen time with their friends per day, and sticking to it. Um, Interactions with teens and adolescents may also include online gaming with friends, which parents can support within reasonable expectations, such as time limits, as opposed to just unrestricted free time playing video games all day. Um, and there are definitely different recommendations, such as like a half hour for adolescents or an hour for teens, um, that parents could try. Now, try to be aware also of any other cultural or language considerations when working with patients and families, especially when their family's first language is not English. The pediatric patient or another family member may take on the role of translator. Translator may view this as an additional source of stress, but it's not a replacement for a professional translator or even a staff member translating. If the pediatric patient does need to be the primary translator, check-in should be done with that child or teen to ensure that they firstly understand the information prior to translation to parents or other family members, and to make sure that the patient is comfortable and not overly stressed by the translator role. Next, Allison will review coping styles you may encounter, additional parenting recommendations, as well as information on the cognitive effects of COVID and school implications.
Thanks, Damien. Yeah, so I'd like to start off by briefly reviewing coping styles. So we know that family and patient coping style can impact psychosocial outcomes in children who are dealing with chronic illness. Given the paucity of research pertaining to psychosocial outcomes in pediatric post-COVID patients, it's helpful for us to look at research that has examined coping in chronic illnesses, other chronic illnesses such as diabetes or asthma. So we know from looking at this research that in these kinds of chronic conditions, a coping style that's characterized by acceptance versus avoidance or wishful thinking and problem solving versus just managing emotions or distress associated with the illness leads to better psychosocial outcomes. Next slide, please, Laura. So with that in mind, we're suggesting that if parents are supporting their children or adolescents to deal with some of these psychosocial sequelae associated with post-COVID, that they might adopt a problem-solving approach. And this is just quite a common problem-solving sequence that I've added in here. So the first step is to define the problem. So an example might be a young person who's finding it hard to socialize with their peers due to fatigue associated with post-COVID. So if we're defining that problem, the parent might say, yeah, you're too tired to meet up with your friends. They could brainstorm solutions. So, they might look at, is there a time in the day that the child or young person has more energy? Would a shorter duration of meetup be helpful? Would it help if the parent drove their teenager to the mall to meet their friends? Or maybe perhaps friends could come to the child or young person's home. So you're just basically brainstorming different solutions. And then the parent and child together would pick a solution, they would test that solution and then review the results. Next slide, please, Laura. Um, so as with any kind of support for recovery and return to function, we want to make sure that this kind of problem solving process or goal setting process is specific. So you want to pick one area to work on and make sure to select a specific goal. So rather than saying to the child, do more exercise, you might set a goal of going for a 10-minute walk each day. Rather than say, see your friends more often, you might set a goal to see friends at least once a week for an hour. It's really helpful to establish the current level of function that's there. So keeping an activity diary for a period of 3 to 5 days prior to engaging in goal setting is really helpful, so you can see where the child is at and then make a good a good guess at where you want to go in terms of setting the goal for the increase from baseline. Usually we recommend that setting goals that involve a 10 to 20% increase from baseline is what's recommended. We want to make sure that the child and the family have about 80%, at least 80% confidence in their ability to achieve that goal. So a child who says maybe they're kind of 50-50 about whether that goal is achievable, we want to go back and look at the goal again and maybe modify it and reduce it. Once children or families have managed to increase things by 10 to 20%, we want to continue to increase in small increments and remind patients and families that one bad day doesn't signal failure. It's important for parents, particularly with younger children, to use rewards and consequences. So rewards might be, working towards a tangible reward, such as a trip to the movies or some V-bucks on their video games or whatever it might be. And when I talk about consequences, I'm not meaning punishment for not achieving the goal, but rather looking at potential reinforcers that might be at play. So for example, a child who doesn't want to see their friends or go outside to play, if they're using that time instead to play video games, you really want to look at managing that consequence, because if the consequence of not going outside to play is to sit and play video games for 2 hours, then that could be a reinforcing factor. So keeping an eye on the consequences. And the next slide, please. Okay, so we're talking about parenting style, and we're talking about, I suppose, parents in helping their children and teenagers to manage post-COVID symptoms. And here we're really seeing the parent as the main agent of change. So in that respect, it's important to look at what style of parenting is best. It leads to the best psychosocial adjustment in children who are dealing with chronic illness. And we know that lots of studies have shown that authoritative or firm but fair parenting leads to better psychosocial adjustments and higher levels of family resilience. So in this parenting style, the parents are nurturing, they're responsive and supportive, but they do set firm limits for their children. And it can be really challenging to parent a child with a chronic illness, and it's easy to see how parents may slip into a more permissive style of parenting in an effort to compensate for the struggles that their child is experiencing, or indeed into a more authoritarian approach in their kind of efforts to affect change and to help their child manage the illness. So really we're aiming to coach parents to adopt that authoritative, firm but fair parenting style. When we talk about parents being main agents of change, I like this analogy of the parent putting on their own oxygen mask before helping their child put theirs on. So we need to be able to support parents to support their children, because a parent who is struggling it's much more difficult for them to support their child in coping with chronic illness or symptoms. So self-care for parents might involve mindfulness practice. It could just involve encouraging parents to activate their natural support systems, friends, family, patient advocacy groups. Healthy lifestyle is always important. Reducing alcohol intake, eating healthily, exercise, all of those things that people are probably very aware of. Next slide, thanks. So I just wanted to, I suppose, finish by talking briefly about cognitive problems and brain fog in post-COVID, children experiencing post-COVID symptoms. Again, the pathophysiology of cognitive difficulties associated with post-COVID patients is really not well understood. What we do know from looking at the literature is that cognitive symptoms include, but they may not be limited to, difficulties with attention and concentration, problems with working memory and executive functioning, so holding information in your mind and using it or manipulating it to carry out tasks, loss of focus, memory problems, and slowed processing. So of course the situation is made even more difficult by the fact that mental health symptoms and ongoing fatigue can also impact a child's cognitive presentation. So it can be hard to disentangle the two things. If we're supporting parents and young people with something like difficulties with cognition and brain fog, it can be helpful certainly to complete some psychoeducation with the family. So normalizing the stress that's associated with long-term symptom management, and then proposing some tools that can be helpful. We want to educate parents and children on how stress and worry can impact their cognitive functioning, and how it can be important to reduce that stress and address that worry in order to take some of that cognitive load away. We might want to discuss the impact of missed school, because a lot of children who would be suffering from fatigue and cognitive difficulties in the context of a post-COVID presentation might have missed a lot of school, so they're out of practice in completing tasks that require a cognitive load. And also, they're missing assignments, they're getting left behind on their work, and that can add to the problem too. So kind of making a plan for school and discussing the impact of missing school and not attending school is important. Now, I also wanted to just highlight that, for any child who's experiencing persistent cognitive symptoms that are not abating and are impacting functioning, you may well want to consider a referral to a specialist tertiary service. The child might require to see a neurologist or a neuropsychologist. So just to bear in mind that when we're thinking of cognitive problems, that we always want to be cognizant that if these symptoms are persisting, and they're causing functional impact, we may need to make that referral to a specialist service. For those children whose cognitive symptoms are mild and are, seem to be associated with that kind of initial period of recovery from COVID, and they're not, we're not concerned that they're persisting too much. We want to support cognition and learning as best we can. So figuring out how much your child can comfortably accomplish currently. So is your child able to read a paragraph, a page? Where are they at? And again, similar to before, identifying small manageable goals to increase cognitive workload in increments of about 10 to 20%. Most schools are in a position to put in place an individualized education plan for a child who's struggling with fatigue, post-COVID symptoms, school attendance. So these accommodations might include a modified school day if that was necessary, um, having scheduled breaks throughout the day, identifying a designated support person within the school, a teacher or a counsellor that the child or young person can speak to if they're struggling. Homework accommodations, it may be very difficult for a child or a young person to complete any homework after school if they're dealing with fatigue and problems with cognition. So looking at that, and then making a plan for catching up on missed assignments, which can cause a lot of stress and anxiety. Again, your basic stress management techniques are also applicable here. Good diet, exercise, behavioral goal setting, and encouraging the use of relaxation strategies. Okay, so we just have a quick knowledge check here, and that is a permissive parenting style is most effective in supporting children who are struggling with chronic illness. True or false? Hopefully most of us are able to get the correct answer to that, which is false. So we did have a short video here, but I think we've been having some difficulties with the video, so we probably will keep going, Laura, if that's okay. I just want to direct people's attention to some of these resources if for people who are interested in learning more, and pass back to you, Laura, I think.
Thanks, Alison. Just a reminder that the Rehab and Allied Health Practice Considerations resource has been posted and just recently updated. If you have updated previous document or the document previously, be sure to hit refresh or Control plus F5 to make sure that your computer has uploaded the revised document. And again, note that the Recovery and Rehab webpage has many other great resources for staff to use. And I'll also draw your attention to previous recordings related to post-COVID. While not all specific to pediatrics, they're all still good recordings and still relevant, and they're available on our AHS YouTube channel. And please tune in, Zoom pending, to our upcoming webinars post-COVID on June 22nd, looking at an episode of CARE, and on June 28th, looking at the physical sequelae and rehabilitation for post-COVID in children and youth. Again, a reminder that the Rehab Advice Line is available for all Albertans from 9 a.m. to 5 p.m. Monday to Friday, and they have been taking calls from children and youth presenting with post-COVID symptoms. And of course, the mental health helpline, which is available 24 hours a day, 7 days a week for Albertans. I will note that if you would like references for this presentation, they are available upon request. They can also be found in the Rehab and Allied Health Practice Considerations document. So while we don't have a poll going up, hopefully everyone can just take a minute to consider how they feel now or how confident you are in your knowledge to manage the psychosocial aspects of post-COVID in children and youth. And hopefully you've seen a little shift and you're feeling a little more confident with this. And finally, a thank you to many folks who've been involved in this work, but here are some key folks who have helped inform the practice considerations document and this session. And I think that that is it. So thank you for joining us.
Yes, thank you for watching our session today. And if you have questions for our presenters, please contact them directly. You can also contact the Rehabilitation Advice Line or the Mental Health Helpline mentioned in the previous slides. And we look forward to seeing you at an upcoming session soon.